Okay, so let me get ahead and start the webinar. Welcome. I'm excited to get this one going. This is a topic that I don't think very many people have much understanding of, or what it really is and how it works and all that kind of stuff. And so today we have some people that are experts on this topic. I know that right now we have Tammy and Kathy with Paradigm, and I'm going to introduce you guys in just a second. I know that Morgan will be here as soon as she can get off the interstate. She said that she's tied up in traffic, so we'll get that going as well. So Lives Co-Pilot is very excited to introduce. And so I'm going to go ahead and start with Tammy. Tell me who you are, who your company is, what you guys do, and then we'll go to Kathy.
Okay, great. Thanks for having me here, first of all.
Thank you for being here.
My name is Tammy Mallory. I'm a nurse practitioner. I'm certified in hospice and palliative care. I work for Paradigm. We provide true community palliative program. And I've been with them for a couple years. And what we do in palliative care is we focus on shared decision-making with the patient and symptom management to prevent hospitalizations.
Okay. So Kathy, tell us who you are. I mean, I know that you're with the same company, but yeah.
I'm Kathy Malloy, and I'm a licensed clinical social worker with Paradigm Health. And I've also been with Paradigm for just a little over 2 years. And I work in palliative and hospice care services and provide support and education and link people to resources, and can also provide counseling, individual counseling under the palliative benefit.
Okay, well, let's go with that. Okay, so now one of you is like social worker counselor, right? And the other one is a nurse. So you guys are doing different sides of the same thing, I am taking it. Okay, so help us with that to understand what that's all about. I don't think a lot of people really understand what hospice is. And I think that even less understand what palliative care is. Okay, so let's kind of get into what is palliative care. When, as a patient or a family member, when do I seek this? Let's kind of go into the very basics of the whole thing.
Sure. Palliative is billed under the Medicare Part B benefits. So with palliative care, you can have all curative services. So you can still see all your specialty physicians. You can have home health care. You can be in a long-term care facility, getting rehab services. And with our program is you're provided a nurse practitioner, a chaplain, a licensed clinical social worker. It's a true interdisciplinary team to help manage symptoms related to life-limiting illness. Not terminal illness, because that would be hospice, but anything life-limiting, such as a cancer diagnosis, a heart failure diagnosis, end-stage renal failure, COPD. There's a long list of things, even dementia, Parkinson's, ALS. So symptoms that go along with those diseases, the social worker and the nurse practitioner and the chaplain go in to help manage not only physical symptoms, but social symptoms, psychosocial symptoms, and just to improve quality of life and to help the patient age in place. Usually we'll have a goals of care discussion, and that's what we base our treatment on, what their goal is. You know, we also have discussions and let them know if they're hospice appropriate, but if that's not their goal, then they get to continue with palliative care as long as necessary until their goal is hospice.
From a palliative care standpoint, from what I understand, it doesn't matter, it doesn't matter age group, it doesn't matter, you can be getting better and get away from palliative care. It's beginning of this diagnosis. What level of diagnosis does it require? I don't care which one answers these, but yeah.
The best time to get palliative care involved is at the time of diagnosis. So if you get a heart failure diagnosis, to pair palliative care with that and to form that relationship, that's when you see the most impact in what we can do. Collaborate with those physicians, make sure that everyone knows the patient's goals, make sure they can, a lot of our patients still work and try to lead meaningful lives. And that's truly the goal, is to keep them in that at that functional level. So even pediatric palliative, we don't provide it, but there are programs out there that do pediatric palliative care.
So Kathy, tell me how you come into this. Tell me how
that's what I was going to say, because you
yeah.
asked like what we do together and what we do differently. So I like to explain it more like this. If someone has a symptom of anxiety or depression, Tammy and I deal with those differently. So Tammy's going to help them a lot with medications and trying to get medications on board to help reduce some of those symptoms. And I'm going to deal a lot with their feelings and emotions and provide that counseling, kind of look at those stressors, look at some relaxation, different, breathing techniques, just really finding the things that might help them reduce those feelings. So we're kind of both addressing it in different ways, but working together. And then we collaborate together and we talk about how someone's progressing and what they're feeling. And sometimes a medication can be increased, or sometimes my frequency can be increased. So we just work together that way and collaborate with the patient's best interest.
So now, do you guys collaborate as a team with their medical providers and things like that? Are you guys involved in keeping track of who's doing what and making sure that they're not getting? I mean, one thing I've noticed a lot of times when you start going to these doctors and you've got 15 different things for different things that are going on in your life, they don't talk to each other very well. Okay, so they're getting prescriptions that may or may not interact with each other, may even be the same ones, that kind of things. I know my mother-in-law one time had 3 different doctors giving her the same prescription. So she was taking 3 times the dose. So how does this work? What do you guys you guys are coming in to work with them. How do you guys coordinate with the team entirety?
I do a lot of collaboration, a lot of phone calls with specialty and primary care. If I notice something like that, I'll bring it to the attention of the team. One of our roles is bringing it all together for the whole team, because you're right, there's not a lot of communication among providers. So my note is encompassing the whole patient, the care that all these providers are providing, and each of them gets a copy of my notes. So it kind of is that communication gap a bit.
So what, so how often does, so you talk about a team, you've got your nurse practitioner, you've got your counselor or your social worker or whatever, you've got chaplain that come with the package, I guess, so that makes sense. That's the right term. How often are they seeing people? Is this a weekly thing? Is it a monthly thing? Is this, how does that work out?
The clinician can determine the frequency with the patient. It's based for my visits, the nurse practitioner visits, they're based on medical necessity. So if there's a symptom that I'm managing pretty acutely and closely, I may see the patient for 2 days in a row just to get things under control, or I may just follow up the next day with a phone call to make sure things are going well. I can see them weekly, I can see them monthly, I can see them every 2 months. It's just kind of, it's based on what the patient needs medically. So there's really not a guideline or a limitation as to how often I can be in there and see them.
I think also what's important to note is that palliative care doesn't replace a primary care physician. And I like Tammy's description, it's an added layer of care. So it's an extra set of eyes, extra set of ears, and added support for that patient to manage symptoms and stay out of the hospital. But anyone receiving this care has to have a primary care physician.
Okay, well, that makes sense. It's like I'm talking a lot of times from my own experiences of dealing with, with challenges, and we're dealing with a family member who we finally got in to see a Parkinson's specialist, a Parkinson's movement specialist. Took forever to get in, and then when we got in there, we got our full 5 minutes. You know how that works, okay, with that doctor. And and basically nothing came of that meeting, but then we read her notes later, and she made the comment that, and we went in there because my mom was all of a sudden falling, multiple times a day, actually, because she was having problems with the movement. As it turns out, there was a comment that they'd never seen anyone have that heavy a dose of these drugs ever. Okay, this is from a specialist, but I thought was kind of disconcerting. But she goes, she seems to be doing fine. I'm going, no, she's not doing fine. That's why we had her in here, So then she was going to see us again next spring. I'm like, no, this is not working. So we've had to really do a lot of work to figure out ways to do things, and we've been able to wean off of some of these drugs, and seems to be improving. But is that someplace where you guys would help catch that kind of stuff in those? Because let's face it, especially if you're older, you've got this going wrong, so you got that doctor, you got this going wrong, so you got that doctor. There's this myriad of stuff, and how do you keep track? So that's what I'm trying to figure out. Is that one of the added areas that the palliative does do?
Yeah, so that's a great question, because you're right. This population has so many physicians, and we do request all of those records. When we get an order to do a consult, if my patient has a cardiologist, I want to know what they're doing for that patient, because what the patient thinks they're doing is not necessarily what they're doing. And if they have a neurologist, I want those records, because I want to be able to bring it all together for them. I review it, and I may bring something to their attention that they didn't know, like, say, for instance, well, the neurologist thinks you may be on a high dose of medication. How did they change it? And that kind of opens up a conversation for me to maybe call if they didn't know and say, hey, is this something we want to address? So we do a comprehensive assessment. It's not a 5-minute visit. My shortest visit, I think, has been a follow-up, and it's been 45 minutes. Usually I'm with them for an hour at the most, and sometimes 2 hours on a new admission. So it's a lot of bringing things together and educating and making sure they know everything that's going on and why they're on medications and why they're experiencing some of the things that they're experiencing.
Well, I think that's something that I think a lot of people go through frustrations with this, and it's just, trying to figure out what these different levels of support that can come into play, So when you're working with a client, so they've gotten a diagnosis, of one of these types of diseases that would be open the door for palliative, and you're talking about, it could be heart, it could be Parkinson's, it could be dementia, it could be, so it's a wide array. It's not terminal, obviously, or you would have a different level of service with the hospice. What does the doctor normally give people the recommendation of the palliative, or are you guys just one of those things that people don't know about you, you're kind of out there on an island?
We have to have a physician's order or provider's order to do an assessment and evaluation. So that does come from the physician, but sometimes we get patient referrals. Families find out about palliative care. They find us on the internet. They make a phone call, and we'll reach out and say, hey, your patient's reached out. Can we go out and see them? We have to get an order for that. And that then begins the journey.
Do you go out and get the order, or do you then counsel the patient to go through the process?
If the patient and the family are able to get that order, that's the best.
Okay.
But our team can reach out to the physician and let them know that their patient's wanting palliative care, and is that something that they're interested in letting them explore.
Okay. So now, who would they be meeting with in a palliative care thing first? Would that be you, Kathy? Would it be you, Tammy? Would it be someone? I mean, how does that process? What's the process of trying to work? Oh, wait a minute. I see that Morgan's here. Let me see if I can find her real quick. So let's see if we get Morgan over here real quick. There we go. Whoops. Okay, so Morgan will be popping up here in a second.
I can answer that question. I remember where you were. So typically the nurse practitioner will admit the patient first and have that first contact conversation, and then can talk to them about counseling services and other supportive services available, and connect those pieces. So they would see someone like Tammy first.
Huh?
I think Jim froze. Can you guys hear
Think
him?
he is frozen. I was trying to weigh in there about the physicians, and I think that my sound must have been cut off, but they did that public opinion research study back in 2011 and then repeated in 2019, looking specifically at physician knowledge on palliative care. And even though they were reporting a lot of growth in that area, I didn't think that the numbers were very impressive. So even though they were saying, okay, physicians are reporting being more knowledgeable about palliative care, I think we're starting to see that integrated into their fellowships and residency programs and reporting more favorable feelings. It was still only 28% of physicians reporting nearly always talking to their patients with serious illness about palliative care, and only 16% of physicians reporting nearly always referring patients with serious illness to palliative care. So I think that highlights a need for those of us in the field and those of us who are passionate to extend that education to all of our healthcare partners, not just patients.
I think we lost Jim, and Tammy and I introduced ourselves earlier, and we can repeat that, but if you could introduce yourself, Morgan, that would be wonderful.
Hi, I'm Morgan McCall. I'm Director of Palliative Care with Intrepid USA.
Intrepid, yeah. Welcome, and I'm Kathy Malloy, and I'm a social worker, licensed clinical social worker with Paradigm Health.
And I'm Tammy Mallory. I'm a nurse practitioner with Paradigm Palliative.
So nice to meet you both.
Good to meet you.
So we are still recording, and I believe I am now the host, which makes me a little nervous.
Here he comes.
Because I've not done this. Here we go. All right, you're muted, Jim. You're muted.
It has to be something to do
There
with
you go.
palliative care. It's like it's trying to keep it blocked off here. Because Morgan, last time I was doing this, we got shut down. So anyway, well, hi, I'm back. I assume you guys were having a conversation.
Yes, we did.
Okay, good. So Morgan, have you introduced yourself yet?
I did.
Okay.
I did. We were just talking a little bit about some of the research you were asking about physicians, and were they prompting a lot of referrals? And really the recent research is showing that there's still a long ways to go.
Is it because they don't know, or they don't really understand, or what do we need to do to do a better job to get people to know this stuff?
I think it's misperceptions. What do you think, Tammy, Kathy?
I agree. I think there's some misperceptions, and it may be one, they don't know exactly what we do when we go out to see their patient, and two, I think there's a little bit of control, and they don't understand that it's truly a collaborative program. And I don't typically do things without notifying my specialty physician or my primary care, because they are running the care for that patient. They truly are. And there are times when the patient will say, well, can't you just do it? You have that ability to prescribe. And I just let them know that, yeah, I can, but it's not being a good partner. And I really need the physician to buy into what we're discussing.
But also agree.
Morgan, you do this on a national level. So, so what are you finding? Is that what you're finding, that's basically where the physicians just don't know, or do you think they're being protective?
I think that there's a combination. We find that a lot of physician offices will think that when we're calling to give palliative care updates, that we're somehow bringing hospice in, and they'll call back in a panic. No, 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 my patient's not ready for that. But we're not talking about hospice at this juncture, right? So I believe that the misperceptions are still very vast, that most, not just physicians, I don't want to pick on the physicians, but a lot of people in general, right? The general public, other healthcare providers are equating palliative care with hospice or end of life care. And that's when many of their referrals are being made, which is not appropriate, right? So we want to swim upstream. And I would agree with Tammy that there's a sense of control, that they're afraid that, okay, is this team going to come in and somehow start directing something that I'm maybe not in agreement with, or that I haven't consented to, particularly among the specialists, you can see that at times. So it's just education. Repetition is the soul of adult learning, and we still have a long ways to go.
Well, I think that part of it is, I've mentioned before, the 6 minutes. I think that's the average time that a physician actually is face to face with their patient. So it's a situation that I think that what you guys are bringing to the table is time, if nothing else. I think that Tammy, you said that your average time is an hour or so that you're with people. More things are going to be evident in that period of time than they are in 6 minutes, so you're going to have eyes on that. If the doctors understand that, you then become a partner to give them information that they would never be able to gather. Or is that part of the argument that we should be making, or can I hear?
That is part of the argument, that when our liaisons are out there talking to physician partners, that they are giving that information, that we're able to see the patient in their environment, and a lot of things translate better when they're in their own environment versus being in that office. You can fake it for 5 to 10 minutes while you're in that office. A dementia patient can maybe fake their ability to be at home alone versus seeing them in their home and in their own environment.
I think it's also the comprehensive nature of what is a palliative assessment, and not just being the physical, but also incorporating in that social, cultural, existential, spiritual aspect, which is very important, because existential pain is just as real as physical pain. So when you have the specialists that are coming in, and you guys were touching on this earlier, they have multiple specialists, but that nephrologist is really just worried about the kidneys. That cardiologist is really just worried about the heart. And so how do we bring everything together to look at that person as a whole, right? And that takes time. And when you're diving into goals of care, their understanding of their illness, their choices for care, and advanced care planning, really walking through that, it does take a lot of time. And sometimes they're tapping their toes to get to the next patient. They might not have time to do that. And the research shows that as well. Even though CMS has been reimbursing for advanced care planning services for, going on, I believe, 5 years now, they're just barely scraping the surface. I think it's 3% of Medicare beneficiaries nationwide are having reported advanced care planning billing. That's just not enough,
It's just because they don't know, probably their families don't know, or the doctor didn't think about it, or what have you. It's kind of where we're at right now. So obviously that's one of the reasons we're having these gatherings like this, to try to get some information out, getting other people to be aware, to at least ask the question when they're in their 6 minutes. That we have, what can we do to augment this? So Kathy, when with you, are you the one that doing the analysis, or how does it start with you? Does it start with, like, I'm going to pick on you two because you're a team, you and Tammy. Who is the first one that usually the first face they would run into?
They'll see Tammy first, and she'll do her assessment first, and then talk to them about counseling services available and see if they're interested in that. And if they are, then she'll send me a referral, and then I will follow up with them individually and do a psychosocial assessment, and help them, with any stressors, help them with their anxiety, depression, and really, provide that support, an unbiased, person, not a family member, not someone that's expecting them to do something, but just to kind of help them sort through some of those choices, decisions, and things they may be facing.
So an ear to listen, that shoulder to listen to, or shoulder to cry on, I guess, if you wanted to as well, right? So,
yeah.
Well, where do we, I know that, we've been trying to get the education on what a palliative is, what hospice is. Palliative is not hospice. In most, like for instance, you have right behind you hospice and palliative. You guys do both, but you're not necessarily going, okay, well, I'm doing this and then this is what's next. It's, and most people don't understand what hospice is anyway. They think it's, a morphine drip the last few seconds, and it's not. It's so much, much more. I really wish that I'd have known what it was when my father was ill, because he and my mom would both benefited tremendously, taking advantage of it much sooner than we did, because we didn't know what it was, because I think we were like most people. So we get this information out. We're starting to educate people to do this. If their doctor doesn't tell them to do it, do we recommend to them to contact you to help them talk to the doctor, or do you want to coach them? If you have a voice right now talking to somebody, how would you coach them into having that conversation with their doctor? Whoever. So that they need to talk to you, or that you guys.
Hospice conversation.
Huh?
The hospice conversation?
No, a palliative care conversation. How would you coach the patient or their families, because the doctor didn't think about it or didn't bring it up, whatever. So when you're making your little list of 6 things you're going to talk about at the doctor's office or whatever, how do they broach your subject?
I don't necessarily coach them to ask their doctor for palliative care, because if I'm there, they've already got palliative care. They've already talked.
Okay.
But
well, you are. Let's put it this way: you're coaching them now on this video.
Gotcha. Okay.
Okay.
For the clarification.
Yeah.
It's been a long day. I would say, I've heard about palliative care. Is that something that you think I would benefit from? I would like to have, someone to be able to spend some time with me and focus on what my needs are from my COPD or my cancer diagnosis. I feel like if I have someone in the home, they could help me and be maybe an extra layer of care to help if I can't get in to see you, or for whatever reason, I have someone. We do have 24-hour call support, so I would have someone to call throughout the night if something were to come up. I would just feel better having more support, because I'm having a hard time. I'm having a difficult time putting this all together, and
as I'm listening to this is a conversation I can see very easily where we need to be having this conversation, how the family member is going to convince the one that's going to go on palliative care why they need to do it. Because the family members are the ones that are probably over here so frustrated going, oh my God, what am I doing? How do I get this done?
Yep.
the patient might be going, no, I don't need that. It's going to cost more money. I don't need this. I can see this being a really good conversation for the loved one, for the family member to talk to the person that might be a potential palliative care patient. Wouldn't you? Because
I think that
maybe your
can go
family's not
back
as
to
hard-headed as mine. Huh?
I think this can go back to the research as well. I'm a little bit of a research nerd, right? So when they talk to patients and caregivers about what do you need to hear or what would be important for you to understand about palliative care, the two things that they resoundingly reported was that they need to hear that palliative care will help relieve suffering and that palliative care is going to help promote the best possible quality of life. And those two things are in the very definition of palliative care. So I think for folks to understand that, number one, do you have palliative needs, right? And what does that look like? Well, if I have a serious illness, right, something like heart disease, lung disease, cancer, right, that's already a palliative need. They might not have additional triggers, but I believe, I don't know if it was Kathy or Tammy, but one of them said it earlier, time of diagnosis is really when palliative care is appropriate for patients with that serious illness. And then as their disease progresses, they may have burdensome symptoms. They may have decision points that they reach, and they need help in weighing that. They may just need guidance for what to expect down the road, right? And so the role of palliative care, if you have palliative needs, right, is to ensure that you understand your disease process, because they don't always. I was actually doing ride-alongs with a nurse just last week. We went and saw a patient who had metastatic cancer. He had no idea that he had metastatic cancer, could not describe that to us at all.
Mhm.
And, so meeting people where they are and then filling in those gaps, right? And that might sometimes require pulling other people back in so that they do understand their condition, they understand their choices for care. And then we're certainly going to talk about what are their values and their priorities, and relieve suffering through controlling symptoms or preventing symptoms. And ultimately, all of this is to promote the highest quality of life that they can have.
Well, as I'm listening to this, I think of different conversations I've had when we've had like hospice expert panels and what they've talked about, that if it's done right and caring for the symptoms, that the person feels better because they're not as in much pain, so they eat better, they drink better, they sleep better. All of a sudden they feel better and they actually can go off hospice because they make an improvement. I can see this same kind of a concept, obviously, at a level that they may go off palliative anyway as they get better with whatever it is they have. But I can see this actually helping to create an atmosphere that could happen sooner rather than later, or what have you, or more likely, or whatever. Is that reasonable to as an argument? Or
I think that some programs will sort of set limits, but in general, if you're just thinking of what is palliative care, when is it appropriate, I wouldn't say that people couldn't graduate, because there's really even been a lot of argument for the role of palliative care within survivorship. So when you think about, cancer patients who move into remission, a lot of times they're still dealing with residual pain or anxiety, depression, things of that nature, and they can continue to benefit from palliative support.
well, that's interesting. I had not heard that before. I didn't know that it can continue on for different kind of support levels, or
Yeah, ultimately, I think the patient and family get to drive that.
okay. So, like, for instance, if somebody gets to bond with you and they're doing things just because they've gotten better on whatever it was that caused it, doesn't mean they couldn't still have that ongoing relationship. Is that what we're hearing here?
I don't know if I have anyone that meets that, but I'm typically seeing folks, alongside the nurse practitioner while they're, in their progression of their disease. I think we have had somebody like graduate because they've gone into remission, and then maybe be readmitted again later if something changes. But most of the time I am seeing people in collaboration with the nurse practitioner.
Well, that makes sense. Yeah, like I said, I have heard it through the other side of it, and I just wanted to kind of figure out where this, where it goes, because again, I don't think everyone really understands what the full scope of this is. So
Most
Morgan,
patients who have serious illness, it's going to be a chronic progressive illness, that illness journey. And hopefully for patients who do get to that point where they're facing an end of life scenario, then we would want to promote timely referral to hospice, right?
So basically, one of the things too is like hospice. The reason I'm getting my head wrapped around this as we're talking, but basically, like, hospice, they have so many months that they can be on before they technically graduate off, and then they could go back on. Here, that's not the case. You can have this ongoing care. Your levels of need of that care can change dramatically, but you're not, kicked off because the time's up or something.
There's no guideline like the Medicare benefit for hospice. It's just based on medical necessity, and like Morgan said, it's family and patient driven. If the patient is typically having a chronically progressive disease, but if they feel they're improving, then that's when we can widen the gap in between visits. We don't have to see them as often, but we can still be in play because they inevitably will have exacerbations in the need.
Well, then also they still keep that same person that's paying attention to what's going on and all the different players and all that kind of stuff. That's a great, that's good to hear. Like I said, I didn't know how those two things separated in that part of the world too. So
I think a good way to think about it, Jim, is that palliative care is really more of a specialty, where hospice is a benefit.
Okay.
If that makes sense.
Yeah.
So there's not really the black and white boxes or criteria that have to be met, where as in hospice, there are those requirements.
Okay. Well,
just like if you were to see a cardiologist and they may see you acutely every month while they're trying to get your heart failure under control, and then widen those gaps in between visits because it's not necessary. It's a consultative specialty care, like Morgan said.
Okay. Well, very good. Well, like I said, that makes sense to me, because I have, because you have to do a lot of these companies that do palliative also do hospice. So it's hard for me sometimes to figure out where the line between one and the other is too sometimes. So this is good to hear. So to be able to understand how the operation is. And did I understand that you said that Medicare pays for this or not? Is it private pay or?
Yes, it's billed under the Medicare B benefit.
Okay.
Yeah.
Because I think a lot of times that might be something that has people hesitate because they're not sure if it's going to come out of pocket, if it's going to come, whatever. So,
and a lot of private insurance companies have a palliative benefit as well. It just kind of depends on what your carve out is through your company.
Okay.
But we do have private payers, Anthem and United, things like that cover the service as well. Especially
younger, younger patients. So. Well, what kind of things would you guys have a voice right now to speak out to people? What is it you want people to know about? So what, Morgan, I know that's part of what your job is trying to educate people all over the place. What do people need to know?
I always like to tell people not to be fearful of palliative care and that nothing is going to be taken away. That's my big push, is we're just going to add. We're going to add to your care, add to that complement, be an extra set of eyes and ears, an added layer, but we're not going to take anything away or tell you have to stop dialysis or stop chemotherapy or stop radiation. I think that's a big misunderstanding between palliative and hospice. So it doesn't take anything away and it only adds.
Well said, Kathy. Thank you. An extra layer. And I think it's important for people to what they can expect, which is typically that they're going to have an enhanced quality of life, and that they get to drive the ship, right? They get to be in control, because a lot of times I don't think that our patients and families understand that, that they do have choices. I think a lot of times they just say, okay, if I need to do this test or I need to do this procedure, or if this is the next step, then that's just what we do. But sometimes I sort of think of palliative care as a much needed deep breath to say, let's take some pause and talk about what are we going to do with the results of that, right? Because I just heard you say that this was your goal or this was your value. So certainly for people to know, if they're interested in palliative care, then they should reach out to a local palliative care provider or talk to their physician about that involvement in their care. And there's a lot of really great websites out there as well that can give additional information. Getpalliativecare.org is a wonderful site intended for patients and family members to visit. They are the intended audience.
So do you guys become like the sounding board as well for the families and for the patient, as far as going, well, the doctor said this and this doctor said that, it's like when you go to the hospital, for instance, I always learn not to pay any attention the first 2 days because they change their mind every 30 seconds. And then all of a sudden they eventually find something they start heading toward. But are you there kind of like to help the client sort through all this stuff and give guidance?
Absolutely.
Yeah,
absolutely. I would say that that's should be a big part of any healthcare team, right? Because navigating the healthcare system can be intimidating and complex at times. I remember my grandmother used to have this book where she would write down, these are all of my doctors and the appointments, and these are the medications they refill. I was like, why do you need a book, to guide this? This is crazy. She was so confused by it. So, I think having a team that can help you with that is really important. It also gives you close communication with your healthcare team and more control over your care as well. But certainly, yes, I would say that a role of palliative care is to help kind of pull everything together, so it's not so confusing and not so intimidating for the patient and the family.
Well, Kathy and I were talking before we went live, so on a couple things about, I'm always been one of these that has lots of questions, and I actually worked with a doctor for a while he was a pathologist, and I was in a real estate industry with him, but I've been too many phone calls where he was chewing somebody out at the hospital saying, what you're doing will kill this person, so it kind of caused me to question things, because I was in too many privy conversations. But in that said, what I found, I remember a situation, I had a loved one that I care for, that he had a thyroid issue that was causing him swallowing issues. And his doctor said that he was either going to have that removed, which the way it was saying, he was going to have to crack his chest open to do it, or he was going to have to put a feeding tube in. Well, neither one of those solutions did this 89-year-old gentleman want to do. But he was so stressed because if he lost 3 more pounds, one of those two things was going to happen. And the way we solved this, we fired the doctor, so because I'm going, neither one of those solutions are ones that we will do. Okay, so we can go this other direction and then figure something else out. I mean, sometimes it's just having a sounding board to talk to somebody and figure out some kind of rational thought process. And by the way, that was 4 years ago. No problems. He had he had some speech pathology to learn how to swallow, and it's been amazing. But literally, they were every day he was stressed out that he was going to have one of these two things be forced upon him. So we need that party out there to listen and to be a
advocate.
Yes, exactly.
Right. Yeah.
Jim, not every family would have pushed back like that. I have met, and I'm sure Kathy and Tammy can relate, I've met countless dementia patients in particular who have feeding tubes, and their families say, we never knew that was an option, right? Where they're trying to make decisions about stopping it. And they say, well, if it had been up to me, I would have never even gotten it. Well, it was up to them, but that wasn't how it was presented.
And that's what I'm trying to tell you. I know a lot of people don't know. I was, like I said, had a weird relationship because I spent 10 years with this pathologist and was in way too many conversations. And I'm going, wow, but so that was a help to me to be adversarial or, to stand up to people, say, wait a minute. But that's really kind of a lot of what you guys provide, is it not? To be that guidepost, that lighthouse to go, let's talk.
Like Morgan said, take a pause, provide the education. It's very patient, family driven. Their goals are our goals. That's how palliative works. So yeah, definitely one of the hallmarks of palliative care.
And I think that's something most families are looking for and don't know you guys provide for them.
Mm-hmm.
So because if sending someone to the hospital without an advocate is a scary thing. Okay. So because I've watched people get pushed around to things. So, so it's nice to have someone that actually speaks the language, and also knows there's alternatives. So, and knows the goals that you guys have said several different times, what the family actually wants to accomplish. So, ladies, we've had a really good one. I don't know if you've got more things you want to say or not. I mean, we don't have to do the full hour. So it just kind of comes down to what you guys, do you have something else that you would like to bring out? You have a platform. I'm going to promote this video across all kinds of other platforms. So, if do you have something you would like to make sure people know? If you had a megaphone, you could tell people.
Do our attendees have any questions?
I don't know yet. Kim has one thing for some of the education. Kim, by the way, if you don't know, is the director for the Parkinson's Association. So,
Oh, wonderful.
First Foundation. I recognize that one. Lynn is a realtor. So anyway, guys, I'm very excited about having you here. I think we had a lot of really good information here. Hopefully people will understand that this is a resource for them and their family members, their loved ones, that they may not have done in the past. And for some reason, we are not supposed to talk about this because it keeps blocking me whenever I try to do this and throws me off. So I'm looking forward to watching the part where I was gone, sitting there, trying desperately to find you guys again. So so last time I ended up watching it, couldn't believe it. It was just great. You guys just carried on and did fine. So so anyway, anybody else have anything to say? Otherwise, we're going to call it an evening and enjoy this nice heat we have out here. So okay. All right. Talk to you guys later.
Thank you.
Thank you.
Bye-bye.
Bye.